Okay, today I'm going to talk about home and community-based services in Hawaii, but I'm actually really talking about Medicaid. Okay, we have home and community-based services that are provided by Medicaid. We also have home and community-based services that are provided through the Aging and Disability Resource, ADRC, Resource Center, yes, ADRC. That's the Office on Aging. And that's their new network that covers statewide. They're expanding their services. They were only providing services to the aged population, but now they're tasked with providing disability and aging resources across the state. I'm not going to talk about their services today. They provide the same kinds of services. The difference is primarily that the services that the ADRC is providing are for private pay consumers, okay? And for our project, we provide services for people who become Medicaid eligible and enter one of our Medicaid programs for home and community-based services. But again, the package and the service descriptions are the same. I hope I'm not going to be too elementary here, because I do in the presentation have like all the services listed with a description. If you think it's too elementary, shoo me on and I can move to the next thing. And then I'm not sure how it works if there are questions afterwards. Okay. So home and community-based services in Hawaii have been with us for about 30 plus years. And back in the 1980s, let's see. Back in the 1980s, it was determined that Medicaid was spending too much money in institutions, basically, and they wanted to look at other ways of providing benefits to people living in the community. So at that time, the 1915C Medicaid waiver programs were created under Section 2176 of OBRA 1981. And that's in the Social Security Act. And initially, back in early 80s, when this was created, it provided for the option of providing these 7 services that were determined to be key services for people who were more disabled or aging in the community. So we have the case management, the home health aid, day program, respite, homemaker, personal care, and habilitation. And as I mentioned, what was happening was a disproportionate percentage of Medicaid resources were being used for institutional long-term care, and there was in the Medicaid program there was an institutional bias. Medicaid never paid for community-based services; it only paid for nursing home care. So if people needed help at home, they couldn't get it. Medicaid individuals have low incomes, so they were forced to move into an institution. And in addition to all of that, as noted, there were concerns about the quality of life and care in a nursing home. So CMS, Centers for Medicare and Medicaid Services, decided they needed to look at alternatives. And so they introduced this OBRA 81 that allowed the states to optionally provide Medicaid waiver services. And what waiver services are services that wrap around the Medicaid mandatory services. So it's a wraparound program. It's not part of the mandatory requirements. I don't have a printout for that, but Medicaid has a very extensive list of services that are provided. I don't know the number exactly, but there are numerous mandatory services. And then there are optional services. Optional services, actually even prescription drug is in there. Our ICF MRIDs for our developmentally disabled folks. Dental is an optional, it's not a required service under Medicaid. Hawaii has been very generous with its Medicaid program, very. I always used to refer to Hawaii as the take care state, because when we can, we take care of our residents, and Medicaid is absolutely no exception. Basically, if you Google CMS or Medicaid.gov, I think it is now, you'll see, you can ask for a list of mandatory and optional services, and you'll see that we pretty much offer everything on the list. Okay, there are only a couple of services that we don't offer, and we plan to continue offering most of these services if at varying levels as we move into changes for the Affordable Care Act. So basically what happened is shortly after OBRA 81, the state decided to apply to provide long-term care services for certain target populations. And we submitted these 1915C Medicaid waiver applications to CMS and were approved. The first three were in 1983. That's our Nursing Home Without Walls program, which you might have heard of before. That program offers services to people who are living in their own homes or apartments. Okay? And then the foster family community care program was developed at the same time, and that came out of a need by Queens Hospital, who was kind of being, they became, I don't want to say a warehouse, but people had no place to go, and they didn't really need to be in the hospital, but they were living at Queens. And so from that, they were our first providers for what we call the residential program, which is our foster homes for individuals who are, actually at that time it was aged. So we created foster homes, homes with 2 people in them, to serve those individuals so that people who are living at home could get nursing home without walls services, and then there comes a time in many families' experience that they can no longer handle, and so they're looking along the continuum to move that individual to a foster home, and then from there move into the nursing home. Okay, foster homes were set up and are still intended to be a family environment. Okay, so it was really what Queens did was really great. They found these wonderful families that were willing to take home individuals that were living at the facility, and so that's where the foster family home concept came up. And at the same time, we had the Department of Health develop a service package for the developmentally disabled. It was called developmentally disabled, mentally retarded. We don't use the term mentally retarded anymore. We use the term intellectually disabled. So you'll see, instead of MR, you'll see ID in the language. So it's DDID. But this was the original 1983 name of the project. In 1990, that's when I came on with Department of Health, so long ago, to start what was called the non-Medicaid Nursing Home Without Walls. And what that was a program that was not funded by Medicaid. It was purely state funded. It was a takeoff of the Nursing Home Without Walls program to provide community-based services on a sliding fee scale in the community. And I can't remember when we closed that program, but basically what happened is because it was purely state funded, it got defunded, and so we stopped the program. And I think that was 94, 95, but I can't remember. In 1992, we started our HIV program, and then in 1998, we started our medically fragile program. So medically fragile is for children, and these were kids who were born and needed to have ventilators and trachs, and that program went for kids that were 0 to 21 years old. Okay, so that was the start of our home and community-based waiver services in Hawaii. And then in 1999, you may have heard of the Olmstead decision, and that was a big case that went to the Supreme Court to kind of fight what was going on in the nursing homes and make sure that people were not housed in nursing homes and that they were receiving services in the most integrated setting. Integration, coordination has been really a key word in all of these services. And even now, the goal is to bring people out of the facilities back into the community in locations that are integrated with the rest of the community. We wouldn't take our DD folks and just put all the DD folks together. You know, they're integrated in whatever the community is, because we're trying to push for the most independent living options for everyone. For Medicaid in 2009, before 2009, we'd already been in managed care, but we expanded our managed care program to include our aged, blind, and disabled group, which would be our group that would be eligible for home and community-based services. That's the same group that's also eligible for the long-term care provided in an institution. And so what we did in 2009 is we expanded our Quest program. We called it QXA, Quest Expanded Access, and we integrated our, well, we started a new program actually for this population that combined services and covered and paid for medical, institutional care, and home and community-based services. And at the time, we were one of the only states that did all three in one place. In most states, home and community-based services were included, but actually the institutional care was excluded, and it was still provided on a fee-for-service basis versus a managed care basis. So what we did then is we combined these programs into one program that was just called home and community-based. It didn't target any particular person. Qualifications are what we call level of care assessment, and then they are part of our home and community-based package. We kept the DDID waiver separate. It's run through Department of Health. It's still considered and funded through, approved and funded through the 1915C Social Security provision. Okay, you hear the term a lot when people talk about long-term care, and I did change this in your handout to the new language. Long-term care is, a lot of people still use that expression, but right now it's mostly long-term services and support. So you hear in the service sector, there's a lot of aversion to calling something care. People want to call it services, case managers, they want to call them coordinators. They don't want to express the need in terms of providing care for people, because they want to be able to, everyone wants to be able to plan for someone who's going to become more independent and be participating in the community at whatever level that is. So we have what we call diversion and deinstitutionalization. And so when somebody starts deteriorating in the community, they need help. For whatever, we start providing community-based services. That might be personal care, nursing, maybe coordinator to come and visit while they're still in the community. What we're trying to do is divert them from being placed in a nursing home. And that's a huge goal of ours. All of those home and community-based waiver programs previously were targeted to divert people from nursing homes. Okay, we did not focus on deinstitutionalization at the time. We are now. So diversion is, avoiding placement, and deinstitutionalization, of course, is moving out of a facility. Okay, some of the principles here are to reduce reliance on institutional care, increase opportunities and services and providers in the community who can provide community-based long-term care. Again, as I mentioned, we want to enable as many people to participate in the community as long as possible. And then we want to look at the funding and create a more balanced long-term care system. Okay? So in our system, we have a couple of key areas. One is choice. We offer choice, even though we would prefer, in most cases, to serve somebody in the community. We offer choice of community services or institutionalization. Okay? And depending on how it's presented and what the stress level of the family is, our goal is to try and keep as many people in the community, build up the service package that's available to them, and delay institutionalization if we can. So this is a choice. And then service delivery in a home and community-based world is provided either by an agency, a contractor, or this process that we call self-direction. Self-direction is someone that's hired by the family. And what's been happening over the years is there has been numerous projects to transition individuals out of nursing homes back into the community, and we're also looking now very seriously at people who are at home having numerous incidents, and being re-hospitalized repeatedly, and then also looking at what they call now and tracking the 30-day re-institutionalization rates. And so that's really key, both in a private pay and a Medicaid world. Trying to keep people who could potentially be repeat ER users at home with appropriate and significant services. The package that we offer here, as I mentioned, this is the Take Care state. Hawaii's wonderful. In a lot of states they offer 3 or 4 services. Some states offer 7. We offer everything. And so we want to make sure that if there's something somebody needs, we can help them get it. And so what we've done is we've contracted with providers in the past when we were fee-for-service. We contract with providers for all these different services, so that when somebody has an assessment and they're determined to need something, that we have a provider base on each island that we can go to and obtain services. And so we have the gamut here. We have in-home services, we have residential services, and then we have additional wraparound services for individuals. In the ADRC, and other avenues where home and community-based services are available, this is the same package of services, and they're described almost the same way, but they may or may not be as plentiful as what we offer through Medicaid, and there might be limited access. And when I say limited access, they may only be able to fund 4 hours a week, where we look at need and availability of assistance in the home, and we are often paying more than 4 hours a week. Okay. The other thing that I want to mention too is these are the services that are offered along the continuum of care. So as people become more disabled, they don't need all these services. Nobody ever gets all these services. It's really the package that they need. But what you see in the community is as people begin to need help, usually it's things like chore services that people need first. They might need companion services. Companion and chore are pretty much the same level worker, so the service looks similar. And then they may need some non-medical transportation to help with shopping and things like that. And that might be like a frail elder who's beginning to start to need services, and the family is not 100% available to help out. And then as things become more disabling, then the amount of services and the frequency of services is increased. Okay. So I'm just going to kind of go through the service package. I'm going to try and go through it pretty quickly. But the other thing that I wanted to point out is under Medicaid, we pay for the services. Unless somebody has high income and they're on what we call a cost share, they pay a portion of their services. What happens because of the program that I'm running right now, what we see in the nursing homes are a lot of people. A portion of the people in the nursing homes are people who never had access to services. They were too expensive, especially as their need became greater, and so the family was, almost kind of forced to place that individual. And one of the things that we look at is, that we're able to do, again, with the diversion and under Medicaid, is to provide enough services to delay that institutionalization. And so now one of the things that we're doing is we're finding a lot of people in the nursing homes who never had the opportunity to get services in the community. And we're finding, which I think is you're aware of, is most people who, not most, I can't say most, I don't know what the numbers are, many people, a significant number of people who are in a nursing home at some point, depending on how long they're there, will convert to Medicaid, okay? So we see a huge conversion to Medicaid to pay for services, and this particular group is a group that didn't have access to these services, and maybe, if they did, might not be where they are, okay? Especially some people that are a little higher functioning. Okay, so under our programs, everybody gets what we call case management. We're not always using that term, but we have a paid service for case management, and under the health plans, we offer what we call service coordination. It's a similar function. The manager, coordinator is responsible to visit face-to-face with the individuals and perform an assessment, and then write a service plan for every individual in Medicaid, okay? Especially, in particular, the ones who qualify or are going to qualify for more long-term care services. And so we have this group of case managers that we contracted with earlier who provided our nursing home without walls services and our foster home services. We are still using these contracted case managers. These are not health plan employees. These are contractors to provide case management services for people in foster homes, expanded arches, and assisted living if they're in Medicaid. One of the key services that's offered in home and community-based services is chore, homemaker, companion. We call that personal assistance level 1, okay? And in that group, as much as possible, we try and have the family provide as much service as possible. And previous to our managed care program, most of the chore level services were provided in conjunction with someone of greater need who needed personal care services. So this was sort of like, while they were there, they would help with the laundry and take out the trash and help with the meals and all that kind of stuff while they were providing hands-on care. Personal assistance level 2 is the actual hands-on care. That's what you hear more in the community as personal care services. So that's when somebody actually needs help. They're usually in need of moderate to dependent services. And so that person can be from an agency, or we also have our self-direction services to provide that. They can use a family member, and we pay them to provide the services. So if they're from an agency, the service can be provided by a home health aide, certified nurse aide. We hold the agencies to a reasonably high standard for their staff that are working at the agency. And then this is the laundry list of services that can be provided. Those are, all of your bathing, dressing, grooming, assistance with the routine health care. It can include medication administration. It can include tube feeding, things like that. Let me see if there's any more on here. Vital signs and things like that. What we do when we use a agency or a self-directed provider to provide this service, especially when we're providing what we call nursing tasks, is we provide a nurse delegation authorization. I don't have any slides on that, but basically that individual needs to have a skills competency to be able to provide those services in the home because they are considered nursing tasks, okay? But the only way that this works is if we have the nurse delegation. It's really, really key to be able to keep someone in the community as long as possible. Numerous functions, even in our for our medically fragile kids, family members and other individuals are trained to do the ventilator care, trach care, things like that. So nurse delegation is really key. Nurse delegation is when the nurse instructs the individual and signs off on that individual's competency to do something. If the nurse does not believe that person is capable or competent, they will not sign off. Okay, this is on the nurse's license that they're approving this person's ability to provide the care. The other thing about that is that on the nurse delegation piece for the community-based services, we're going to pay for those services. So that individual, if they're from an agency or if they're a family member that we are paying to provide nursing tasks, they must be competent or we're not going to pay for them to provide the services. Respite, you hear the term respite all the time. Respite refers to a lot of different things, but respite is short-term. Long-term personal care and other services usually go by the name, personal assistance, chore, whatever. Respite is temporary, okay, and it includes a gamut of services. Every agency, every program refers to respite a little bit differently, okay. It can be, we pay for it by the hour, by the day. We also cover institutional overnight respite. Sometimes that's necessary. For the most part, yeah, it is provided in the home, but it could be provided. We have respite that's considered daycare. This one can be consumer directed also. Okay, consumer direction, self-direction, those are two terms that are used, that are used in mixed ways. This is our project. We started this in about 1998. We added self-direction, paid self-direction into our home and community-based services. This is really, really important. There are a few ways to implement self-direction, but our way is guided by an assessment of our coordinators, our service coordinators, our case managers, in conversation and coordination with the family to identify what tasks need to be performed and which individuals are going to perform them. So oftentimes it's a family member, someone who, we need someone to be home to provide the service. Oftentimes they're reducing their hours at work to do this. They can't financially afford it. We do not pay big bucks for this. We have 3 levels of self-direction. The first level is our PA1, that's the chore level, and that's minimum wage. And then the second level is when we provide the hands-on care, that's our PA2, personal assistance 2. And that one right now, it needs to go up, but it's only $8.50 an hour. That's hardly anything. And then we offer a little more money when the tasks are delegated. So for the period of time somebody's providing a delegated task, we will pay a couple dollars more for that time. So sometimes people have a blend of authorizations under self-direction. Under self-direction, it's supposed to be the individual who is the employer, okay? So this is like an employer-employee relationship, and they are supposed to be able to do this recruitment, training, scheduling, supervision, evaluation, and then if there's a problem, they're supposed to be able to terminate that provider, who might be their sister. Gets a little complicated. So we're working with individuals to do that, but on the other hand, when we come in to monitor and things are not being done, that provider has to be terminated. We're not paying for them just to have money and be able to stay home and be with that individual. So there's a responsibility there. Not everybody is able to be an employer themselves, okay? The client or the participant or the individual is the employer. We have an option for a surrogate, and a surrogate is someone else, usually another family member, who takes on that role for the individual. And that happens perhaps in a behavior situation, or sometimes if somebody's severely developmentally disabled, somebody could be not able to communicate, okay? the family member may take over that role and either hire someone from the outside. They can advertise and hire somebody from the outside. They can hire their neighbor, or they can hire another family member. And so that surrogate is the person who signs off on all of the paperwork for this program. They approve the hours, they sign off and confirm that the hours were provided. And the individual, if they're capable, can change the surrogate at any time. The surrogate, who is the employer, cannot be the employee, okay? So if you are overseeing the work, you cannot be the provider. It's really important. We didn't used to allow parents to be a provider, and we didn't used to allow spouses to be a provider. That was considered to be a required duty of that individual, but we have some flexibility now since we went into the managed care for long-term care, and we allow less than 40 hours a week to be provided. Okay, I'm not going to go that much into daycare. I think daycare is a lower level than day health. Day health is more a medical program. It's usually in a facility. It's in the day health program. They're more equipped to handle more medically compromised individuals. There has to be a nurse on site. And there's a lot of medication administration, tube feeding, and things like that that go on. There are not very many day health programs here, okay, or statewide. And there are more daycare programs. There's a lot of daycare programs. And daycare, the smallest daycares can have up to 4 people, but they can be rather large, and they need to have appropriate staffing. Both of these options are licensed. Okay, so daycare is licensed by Department of Human Services right now. That's going to switch. And day health is licensed by Department of Health. I think daycare is going to be moving over. And for individuals that need nursing or medication administration in a daycare, there has to be nurse on oversight. Okay. Private duty nursing is another option. We pay for that. That's different. This is ongoing private duty nursing for people who need nursing tasks every day. And so that's different from home health that comes in for a couple weeks after a hospitalization or an incident, and then they're done. This is ongoing, permanent long-term care. And we call it private duty nursing. Most of the agencies that provide this are the same agencies that do the home health. They're licensed. The nurses are all licensed. The agency that does private duty nursing may not be licensed. Okay? We don't have licensing for private duty. We do have licensing for home health. One of the first things that somebody needs when they start to need help is home delivered meals. They're not always so delicious, but they're delivered in a lot of different ways, but we allow up to 2 meals a day, depending on what the circumstances are for that individual. If there's someone around that can cook, they need to be cooking and putting in the freezer. For home delivered meals now, a lot of it is frozen delivered meals. So they become very efficient. They'll deliver 5 meals in one day for your freezer, and then everybody's supposed to microwave them. And so these are nutritionally sound approved meals by places like Lanakila, and I'm trying to think who the other one was. Okay, sometimes as people become more disabled, their home is not really a safe place for them to be. And so we have 3 options that we pay for. We pay a service payment for 3 different residential options. One is assisted living. And the assisted livings, I think this is an assisted living, isn't it? Mm-hmm. Craigside. The assisted livings don't usually want to work with Medicaid because we have low reimbursement, but Oceanside on this island is the only one that we're working with right now, and Basically, that's a fabulous environment. Assisted living is wonderful. It provides all of the independent living feel that somebody wants, so that they don't feel so disabled and so needy. And so being able to live in a place like this where they can move around, eat with a group, participate in activities, that kind of thing, go outside is, that's the ideal for home and community-based services that we really like to pay for. We, as mentioned, Queens started our foster home program, and originally it was only 2 people in the house, and everybody had their own bedroom. Now it's a little bit different. There's been a push to increase the number of people to 3 in a foster home, and bedrooms can be shared. And so this service is certified. The caregivers in this service are all nurse aides, certified nurse aides, and homes are monitored and certified, which is very similar to licensing, by DHS. Everyone who's in a foster homes were set up for the Medicaid waiver program, so there has to be at least one, in some cases there has to be 2 Medicaid clients before they can enroll a private client. There are private clients in foster homes, but they cannot admit a private until they have at least one Medicaid. And if the Medicaid client is discharged or something happens, they must immediately fill that bed, okay, if they have private pay clients in that home. But it is an option for private pays.
Is that the result of the couple in Hilo?
The result of the couple in Hilo is 3 in a home.
Oh, okay.
Yeah, that one and intermixed with private pay. But many years ago, prior to that, we did go to Medicaid and private pay, but because this was established for Medicaid clients, see, if we didn't establish this for Medicaid clients, we'd have no place to put them, or no place for people to go, because the next option is the Arch, and the Arch is primarily private pay. They're charging same rates as a nursing home, and most of them will not accept a Medicaid client. So it's a really big issue. And if we allow the foster homes to become like the Arches, we will have no place other than a nursing home for people to go when they need help, more help than what's available for the family. So this option, the adult residential care home, is a really great option, okay? And the basic Arch is set up for people who meet the criteria on assessment the Department of Health does, but they don't have to be totally dependent. A lot of people that are in Arches go out during the day. They need someone to help them with their food, with their laundry, that kind of thing. It's bigger than an apartment in terms of the services they get, but they have the ability to go out and come home. A lot of people in Arches are people who are affiliated with Adult Mental Health Division. And there are also a lot of people who are in our DD waiver. And many of these people are, they can still, they walk, they express themselves, they're able to eat by themselves, so they don't really need hands-on care. They might need some cueing and some reminders, but they don't need the physical assistance that people in foster homes need, okay? In order to get into a foster home, you have to be nursing facility level of care. We have an instrument that we use for the nursing homes to determine if someone is eligible to live in the nursing home, and they must be reasonably disabled. We have a point scale for that, and the point scale has been enforced at a higher level. And since we started managed care, there have been people in the nursing home who are more functional, who have been asked to move on because they're really care home level. They don't need the nursing home. They could go to a care home. They could use the help, but they don't need nursing home help, okay? Nursing home care is very expensive. And so, for the Arches, there's 2 levels. There's a 5-bed Arch, and then there's 6 or more, like Luna Lilo is a type 2 Arch. But your small homes are up to 5 beds. They don't have to fill every bed, but they can serve up to 5 beds. And they may or may not be licensed for all 5 of them. You know, our goal between the care homes and the foster homes is to make everybody home accessible. Not all the homes are accessible, so it's not always appropriate for someone who is extremely disabled to move into a care home. What's happened though, and over the years is, I don't remember what year this was, we expanded in our residential program from foster to add the arch. And that was with Colin Hayashida, who was here last time, I think, when he was at Maluhia. And what they did was they created a licensure inside of the arch to allow the arch to let people age in place. And so, or to admit people who needed nursing facility level of care. So the type 1 5-bed home is now, can get licensed to serve 2 to 3 people who need long-term care services, okay, as an alternative to placement, okay? And in the type 2 arches, which are the bigger ones, they can admit 20% of their population to be nursing facility level of care. Here in Hawaii, our nursing facility level of care, as I mentioned, is pretty stringent. It's quite different than on the mainland. On the mainland, you see, like in home and community-based services, you see a much more functional group receiving home and community-based services. Here in Hawaii, in the nursing homes, that's why the acuity level in the nursing homes is so high. Our level of care instrument has a reasonably high cutoff, and so most of the people who qualify for long-term care services are pretty disabled. So in the expanded arch, same thing as a foster home. It's a 24-hour facility, and in the residential, the E-arch and the foster home, people can be admitted who need nursing care. We have some homes that have nurses as caregivers, and then we have delegation services that are in place. Okay, moving assistance, if somebody really, the house is unsafe, they become more disabled, they're in the program, we can help them to pay to move to a more accessible location. Home maintenance, we offer, let's say somebody's in a nursing home or they're in the hospital and their place, maybe they're a hoarder, or they live in a very rural area with all kinds of stuff around their house and whatever. We have this, and maybe they have a lot of roaches, you know, whatever it is. We have a one-time home, we call home maintenance service, that we can offer to help clean up the place before the person comes home. Because the last thing that we want is for them to go back into a home or continue living in a home when we pick them up that is unhealthy and going to promote them going to the ER numerous times or falling and having an accident, breaking a hip. So this is like the heavy-duty cleaning kind of things, okay? Minor repairs, non-medical transportation is also something that we do. This is not to be confused with emergency transportation, which would be like an ambulance, or medical transportation, which is covered by Medicaid to go to the doctor or any kind of medical appointment. This is in our home and community-based package. This is to help people get to a day program, a day health, or some authorized social event. Counseling and training is also available. Sometimes caregivers need more assistance, sometimes to learn how to do the tasks, and we might need to pay for some of that. We also might need to pay for some behavioral health kind of services for the family or for the individual. This involves a ton of things. And originally, counseling and training, I think, came up when we introduced our HIV program, because we needed to have more counseling and training for caregivers and families to acclimate everyone and help them out. We pay for some, I wouldn't say renovations, we pay for some modifications. And the modifications that we pay for are, we try and stay as basic as we can, because it's very, very pricey, especially on the neighbor islands. But mostly ramps and grab bars and doorway widening and some renovation inside the bathroom. It's all very, very expensive. It's a really expensive service. The person is supposed to own the house. It's not really supposed to be a rental. We have to have approval if it's a rental and decide whether it's a value added situation to pay for something in a rental. So there's not a lot of this, but we do it. And again, just like most things, we go to the family first. We go to, like in this environment, if it's a rental, we'll go to the landlord first and find out if they're willing to do it or what they're willing to do, and then we might, be able to work with them to accommodate that individual. But all these things, we look at the family as the first provider, and some of them we look at neighbors and friends. Medicaid pays for a lot of things. It's very rich in terms of equipment and supplies. And there are some things that are considered non-essential but helpful for actually they become essential but more helpful for somebody who's becoming more disabled and needs assistance. And these are things like specialized infant car seats, modifying a vehicle so that someone in a wheelchair can be transported or drive. We pay for some electric bills for people, particularly those kids that are on oxygen concentrators, and shower seats and things like that that aren't normally covered by Medicaid. The other key thing, which is up there with the home delivered meals, is one of the first services that people usually get when they're living alone in an apartment before they really need a lot of hands-on assistance, is personal emergency services, response services. That's the button that people wear. They can get help if they fall. They don't need people to be there all the time, but they do. If they fall down, they need help immediately. And so we pay for that. We also pay for, we like to pay for this for someone who's living alone. If they are in a family environment, we tend not to cover that. We would like some coverage by the family. But we want to, there's so many people out there that have their own apartments, and we want to encourage them to be able to stay safely where they are. So we also pay for beepers and bracelets and intercoms. Lifeline is the emergency, the PERS, 24-hour answering, anything for fire and safety, light fixture like blinking things, and whatever is proposed, we're open. And now, in the changing world that we have, there's a lot of new items out there. Some of them are pricey, but this is the DD waiver. We still have the DD waiver. It's not combined with our regular services. You see, the package is almost exactly the same. They have a few things that are a little bit different. That residential habilitation, they don't have that anymore, so you can cross that out. I forgot to delete it. Just a couple things about what they have is the DD waivers. They have a service called habilitation, because most folks that are in the DD waiver are not so compromised that they need a lot of physical assistance, but they need cueing, and they need to be able to go out and participate in the world. And so this is habilitation that they get. They get kind of an assistant who accompanies them on different day outings, things like that. And that person is trained to train them while they're out. So it's not just like, going out and having a good time. It's, teaching essential skills in the process. And there's different levels. We have a real wide variation of people with behavior issues in our DD program. Some people actually require 2-on-1 assistance and 3-on-1 assistance. The other thing for in the DD waiver that they offer is supported employment, and that's becoming more and more popular across all networks. For individuals who could be working, they become more disabled, they lose their job, maybe they never worked before, but looking at vocational rehab kinds of things and various settings where they might be able to be trained to do certain tasks and get paid. And so we want to try and get as many people employed. They have emergency services of outreach, shelter, and respite. They have assistive technology, which is like equipment and supplies. in the DD waiver, they might be able to get a computer or something like that to help them out. The modifications are separate, so there it is. And then we have where we're at right now. We're doing a lot of deinstitutionalization. And as I mentioned, when we first started the process, we were pretty much focused on diverting people from entering a facility. Right now, we're looking at, and that is part of my program too, the Money Follows the Person grant, and working with the health plans that we have right now to look at who's in the facilities. Do they all need to be there? Do they all want to be there? That's the key question. Do they want to be there? Now, a lot of people get asked the question, would you like to go home? And then they really don't have a home anymore. That's a big issue. So we're working through those variations. But the nursing homes, we're not asking that question. As of about 2 years now, it's the assessment form inside the nursing homes has been changed. It's called Section Q, where they're forced to ask people, do they want to go home? And then if they say yes, then there has to be a meeting. So, so this is what we're looking at. We have, with the closure of Waimano, Waimano was for the developmentally disabled population. It was a larger facility up in Waimano, and we no longer have any facility like that here. We have instead 17 small 5-bed homes. Okay, these are the ICF ID facilities, and there are about 17 of them. They are licensed to serve up to 90 people, but right now we only have 77 people in those facilities. CMS, you know, in its push to rebalance the system and look at, you know, why is everything so focused on institutional care? They have offered numerous grants over the past years to states to work together with nursing homes to try and move people back to the community and increase the availability of home and community-based services. So in 1998, as early as 1998, 2000, there were some grants, and then there were 33 nursing facility transition grants in 2001 and 2, and then later in 2008, which is part of what we're part of, they introduced the Money Follows the Person grant. And right now, there are about 45 states that are getting Money Follows the Person funds. Originally, the funding was supposed to stop in 2012, but it's been expanded to continue through 2016. And in our project, we're looking at rebalancing, increasing the percentage of home community-based services that are out there in terms of where people are, the numbers, you know, living in a nursing home versus living in the community, and then where the dollars are being spent. And then we want to make sure that we have quality along the way. Some states have been very creative, and we need to get more creative over here about what we offer in terms of alternatives and what we can offer to perhaps some of the nursing homes to look at the way they do business and what additional services they might want to provide, or do they want to convert to some other service sector. And so what some states, this one is mostly from Washington State, but what they do right at the get-go is anybody who goes into a nursing home, regardless if they're Medicaid or not, they get assigned a case manager and they get an assessment to determine, do they need to stay here? Because when somebody goes into a nursing home, after they've been there a few months, they're kind of planted, okay? You know, they're comfortable, they may not want to go home. The family is used to not having them at home. They don't want any disruption back at the house. So really, the key is to identify and assess people the minute they get there. And a lot of people, more and more, we see the nursing homes being used for rehab purposes, which is good. But both the facilities and their discharge planners and anybody that's connected to that individual needs to be working from the get-go to look at, okay, what are the alternatives? You know, how do we provide that? Is it possible to move back home? And so, or to move to a foster home. Many people, what we're finding here in Hawaii, because we have such a huge foster home program, people are very willing to go to the foster homes. move out of a nursing home and go to a foster home. It's a family environment, they have space, they're not dealing with all these other people, they're not dealing with all the noise, those kinds of things that occur in a facility. So it's a very significant number that move from a nursing home to a foster home. Like I said, they prioritize the new admits and then the folks that have been here longer. The program that I handed out the brochure for, the Money Follows the Person, Going Home Plus locally, originally the goal was you couldn't admit somebody until they'd been in the facility for 6 months, but they discovered that's way too long. Why wait 6 months? Because by then they're planted, okay? The family's used to not having them around. It's much harder. So they changed the requirement to 90 days, okay? And that kind of fits in with Medicare reimbursement and other services that are available, typical rehab. So the bottom one is the one, civil penalties, nursing facility capacity reduction and bed conversion strategies. Okay, that's really key in a lot of states. Most states are overbedded, okay? That's not so much our problem, okay? The acuity level in our nursing homes is very high. If you look nationally, there are huge numbers of nursing homes that are not full. And so the Money Follows the Person program was actually set up primarily for the DD population to close down the big warehouses, the big Waimanos, much bigger than what we had, in the other states, because most other states have a Waimano kind of huge facility, but they have numerous facilities, and the care was not adequate. And so they're looking at moving people out. And when you go into some of the facilities, even ours, there's a percent of the population who doesn't really need to be there. They're higher functioning. They're there for various reasons. And so that's a population who might benefit by either moving back home, moving to a foster home, or finding an apartment and getting adequate services. As I mentioned when I first started, the private pay population has not had access to all of these wonderful home and community-based services that would have helped to delay their institutionalization, okay? We're finding them in the facilities now, and they don't all need to be there. There's a reasonable population in our facilities who could benefit by living outside the facility. So we're trying to identify who those folks are and support the process. Doesn't happen overnight, but we're also looking at different facilities who want to do a conversion. They realize that maybe there's other things they can do. They can provide additional services. Maybe they can convert to an assisted living environment. They can be part of an assisted living environment. There's different opportunities that people, we're working with different facilities and different individuals in the community to promote, to get people to consider what some of the options are. It's sort of like, I don't know if everybody was around, like even when, I'm trying to think what year this was, but before we were really good, I don't know how good we are right now about rehab in nursing homes, but there was a period when we weren't really using our nursing homes in that enough in the way of providing rehab. And any kind of change is hard, right? People really couldn't see how to convert or increase the amount of rehab. What does that look like? How do you do it? And now almost every facility is providing rehab at some level. It's really a huge improvement. And with rehab, you have a much higher potential too to get people out. So we're looking at all of that. What we do in our project, we try and meet with facilities regularly, and what we do is we talk to them about preparing somebody for discharge. We really want the discharge planners and others, but we're primarily working with the discharge planners, to think discharge. When somebody goes into a hospital, you're supposed to be thinking discharge from day one, right? Well, same thing with a nursing home. Is this person going to be a candidate for discharge? And how do we make it so that they're successful in the community? We want every discharge to be a successful discharge. sometimes there's extra costs involved with that, but we want to encourage the facilities to look at, have they been doing enough for that individual to bring them up to a level where their PTOT, they're able to walk a certain distance, they're able to use utensils, they can participate in their transfers, that kind of thing. Has there been continence training? One of the ways that people get to stay in a facility is because they get checked off because they can't go to the bathroom. But there's a significant number of people in facilities who can be trained to go to the bathroom. And they may not be very good at it, but some people will be. And this is often not a priority, okay? Because it is a key to keeping somebody in a facility in terms of the assessment. Diet. We have a huge problem in the state for obesity. We've got a huge number of people who are very large in facilities, who are very hard to discharge, but really don't need to be there. And this is my pet peeve. This is my next thing. I like to start a program where you can't bring outside food into hospitals and nursing homes. Because the kind of plate lunches and all this food that's coming in is not helping a person staying in a bed to look at their health and their size. And so, looking at individuals, especially diabetics, who could be doing some kind of weight loss program at the facility, where there could be some training in limiting the amount and type of outside food that's coming in, that kind of thing, doing the education. And then, when people have been living in a facility for a long time, they're scared to come out, and so, there needs to be some discussion, maybe even some psych work to prepare the person to move on. And a lot of people are afraid, and so, having the right services available. This also plays into diet control, okay? A lot of times there are some psych issues on diet control. Psych is not paid for in the facility. Medicaid doesn't really pay for it, but it's really important. And any way that we can move in that direction would be huge in terms of changing attitudes, assisting people to be more independent, preparing them for what comes next in all aspects. And then medication management. I mean, that's always, discharging people with large numbers of pills and things like that. So really looking at, and when we first started this program, people were not looking that closely at the number of pills that people were going home with. I mean, how do you manage 20 pills? I mean, how do you do that? I don't know. I was just looking at somebody's record yesterday, 25 pills in a rural area, blind. I mean, that's like a recipe for disaster, So what can facilities be doing to reduce the pills? And a lot of this stuff occurs within the week or two before discharge. This is when, these changes need to be implemented. They need to be implemented before discharge. Again, we're looking at success. We want every discharge to be a success. We do not want to see them coming back in a week. The other thing is there needs to be a family meeting, and family members need to be trained in the person's care. They cannot be just called to pick up the individual on Friday. They need to get the training on that person's care so that they're comfortable doing the care. Because if they're not comfortable doing the care, it's not going to get done, or there might be some errors. There's going to be errors anyway, but we don't have to have as many. These are the problems that we're running into, which of course are quite obvious, most of them. We need more respite homes for families who are having trouble or burning out. We need options for them that is affordable, so that they can temporarily, maybe they need to go to the respite home themselves. Something, where people can go temporarily for a break. And it's not just the caregivers that need a break. A lot of times, it is the individual who needs a break from their caregivers or their family. But these complicated areas are problematic. We are working with families, and we're also working with our foster homes to be better and willing to accept individuals who have these medical problems. These are kind of our biggest problems. And then the hospice one is down there too, because especially in a foster home, people tend not to want somebody to die in their home. So some people have really, risen to the challenge and really want to be a hospice home, but most people don't really want that to occur, especially when the family has small children around, that kind of thing. So these are kind of our working areas, and then crisis intervention. There are crises, and I'm not sure that we have the right system to address it. People end up in the ER, and we need alternatives to ER for crisis intervention. What we're finding, and what other states have found, this is not that different, we're finding the same things, is that people are satisfied. People who have moved out, especially like in this program where we're actually monitoring it, we do a satisfaction survey. We do a satisfaction survey in the facility before they leave. We do one year later and 2 years later. And we have a very high retain rate in the community. People are happy to be out. They feel like they're getting mostly adequate services. We have 35% of our people returning home, and 65% do go to a foster home. We knew that when we started. We knew that the alternative to go home wasn't always there. And then most people are still alive, which is good. We like that, and have completed this program that I have is a 1 year, 365-day program. This program, under Money Follows the Person, what it is it's an aggressive program to go to the facilities and discharge people who want to be discharged into appropriate environments with enough services. And we get, for the first 365 days, we get an additional federal supplement to the state's 50-50 match. We get 75 for 365 days. Okay, people think there's no quality going on for home and community-based services. Believe me, there's a lot of quality activities. There are several areas that CMS looks at for our waiver programs, and parts of this are incorporated, if not the whole thing, in different ways in our managed care operations. And we don't exactly label them the same way, but the first one, the first assurance that we make to CMS is level of care, that the person meets the nursing facility level of care. And that they have, the framework for that is access. You know what, if you want me to stop.
No, okay.
Okay, everyone who requires home and community-based services gets an assessment, and they have a service plan. That's required. And the focus these days is for the service plan to be member-directed as much as possible. It's this whole concept of person-centered planning, which really started in the DD community, has exploded to everybody else. And the focus is for a more non-medical environment that looks at the individual. So often in the nursing home, and because so many of the managers for these programs are nurses, the fix is medical, not the person. It's like, there is a real person there, and they actually are interested in certain things. Find out what they are. Make it person-centered. And so that's a lot of the framework around the service planning now. Member rights and responsibilities. The choice issue, do they want to be here or there? They have certain rights that are protected, both privacy and other. And we are looking at their outcomes and satisfaction. We operate numerous satisfaction surveys, and people have the right to appeal when their services are reduced. So these are all like, what do you call it? These are all like safeties that are incorporated in all of our programs, particularly in managed care. Every provider has a qualification, especially under Medicaid. We are required to follow or to identify what the provider qualifications are for each home and community-based service, and then we recruit providers based on that. And for most of our licensing from Medicaid requirements, again, most of the certifications are certification, licensing, very heavy on that end. We can't just hire the neighbor, except in the consumer-directed program. Okay, those are sort of the well, the provider qualifications. I'm at a loss for words here. So we do that in our home and community-based services. We also do that under managed care for home and community-based services and the other services that are provided. There are very strict provider qualifications. These things are monitored on a regular basis. There are reports that are written and submitted to the state for certain areas here on a quarterly basis. We track incident reports. So if somebody falls, if they're abused, if there's a police report, if they run away, those kind of things are all documented and reported to the state. And then we look at how we're going to improve those outcomes and reduce them. Internally, we're looking at how is the system working? Are there policies and procedures? What are the trends? What do we need to do next? These are things that we look at so we can plan for the future. And we also want to make sure that everybody is billing properly, being paid properly, you know, that we're not running into an excessive amount of fraud. Some fraud happens, right? This is the quality cycle. Basically, there are monitoring reviews, and that's when you discover what's going on, and then from there, if there are problems, then there's a whole remediation process that's documented and follow-up is occurring. And then we're looking at improvement. What kind of system changes need to occur to fix this? Is it systemic, or is it just in that agency? You know, that kind of thing, and how do we move forward? So we're always looking at the results of any of the reviews or any of the various reports that we receive, both through our managed care plans and our home and community-based services. In addition, on the program that I have for nursing home transition, this one has additional requirements, and those are a more strenuous critical incident reporting process, a 24-hour backup, documented backup strategy. Everyone that comes in there's about 8 areas that they have to address about what's the backup for the equipment, what's the backup in case your caregiver doesn't come, you know, et cetera, et cetera. People have to be identified who will come in and assist that individual when they need help. That's the 24-hour backup strategy, and then, you know, the monitoring of all of those things based on reporting usually. Okay, why the additional review? Well, people coming out of nursing homes are very vulnerable. I mean, everybody's vulnerable, but this is a really vulnerable population. And typically they're very dependent on the institutional nature of the services that they were getting before. So this is, you know, a new ball game for them. And they may think that they can do things that they can't do. They may not be prepared to really move out. And so, you know, they're more at risk for either being injured or whatever. That's it. We're done.